Good afternoon, Colorado. I'm Kim Bimsteffer. I'm the Executive Director for the Department of Healthcare Policy and Financing, and welcome to this session of the State of Reform conference here in Colorado called Changing Purchaser Strategies for Controlling Healthcare Costs. We're very delighted that you have selected this session, and we hope that it is a rewarding one for you. So we have, in addition to me, two additional presenters. So I want to introduce Claire Bruckbank. She is the CEO of Peak Health Alliance, and Dr. Gregory Tong, and Greg is the Associate Professor of the Colorado School of Public Health. So we're going to take it in this way. I'm going to do 10 minutes, and I'm going to talk about Medicaid as the largest payer in the state. And then Claire's going to represent employers and individuals through Peak Health Alliance, and Greg's going to talk about a unique program that was through House Bill 1176 and a report that was released earlier this year. It talks about what's the differences in the various ways that we could provide health insurance coverage and overall coverage to all Coloradans. So he's got an interesting perspective from public health perspective, and then employers and individuals, and again, I'll take Medicaid. So with that, Emily's in the background. Emily, why don't we go to slide 2 here and slide 3. So again, as the Executive Director of Healthcare Policy and Financing, that's the department inside Colorado that provides coverage, safety net coverages. So Medicaid, Children's Health Insurance Program, other safety net programs like adult dental services, things like that. But through Medicaid and CHIP, the department is now covering 1 in 4 Coloradans for health insurance coverage. That's pretty remarkable during this downturn. So since March of 2020, we've grown by 24% now. The screen is a little updated as of this morning, and 295,000. So next month, I should say, we'll hit growth of 300,000 folks. And so if you look back about a decade ago, we were covering 10 or 11% of the state. And with the expansion of the ACA or Obamacare that expanded Medicaid, that added the exchanges, Medicaid is now really a significant player in the market. So let's go to the next slide. So because of that, and the cabinet position that I hold with the governor, when he looks at us, he says, look, bring your trusted position in the industry. So we don't have stakeholders that cloud us with earnings objectives. We're not concerned with market share growth. We're concerned with serving individuals who need us. In this case, low-income Coloradans and individuals who are disabled. And when 1 in 4 folks are qualifying for Medicaid, that's a big deal. So we wear a couple of hats. And as a payer, so one is these reports are examples of the trusted partnership we have with Coloradans and employers, elected officials, and others to give facts, transparency that shines a light on the solutions that can be used to bring more affordability, which is one of the top concerns of employers. As soon as we get through COVID, it will continue to be the top concern of families and of all issues for affordability. So affordability of healthcare. So you'll see some of these reports that you can link into any of these, whether it's hospital profits and revenue costs, or reducing prescription drug costs and means to do that. There's a report out there on maternity. Medicaid and CHIP, Children's Health Insurance Program, represents 40 to 45% of the births in the state. So we're analyzing things like health disparities to bring solutions to close disparities, which is so important to all of us, or telemedicine. So you'll see a whole lot of affordability reports and suggestions coming out of our department, and others like Claire will use these reports to help negotiate better deals. Let's go to the next slide. So we are right now one of the top 10 states for healthcare when it comes to hospitals, profits, prices, and costs. So that's in our mind's eye. So when we push forth initiatives like the Hospital Transformation Program, it's a value-based payment of more than $1 billion between our department and our relationship with hospitals, as one of the largest payers to hospitals, that pays them a value-based payments to transform for the betterment of all Coloradans, not just Medicaid. So we might pay them a value-based payment to shut down standalone emergency rooms because they've been proven to cause costs to go up, not down. We might pay them to add mental health, behavioral health beds, mental health and substance abuse, because that serves all Coloradans, not just Medicaid. So we use our position to be able to work with the federal government and drive value-based payments as the largest payer in the state to help transform hospital behavior and performance to the betterment of all Coloradans, with the biggest value-based payment that we govern now in collaboration with the hospitals called the Hospital Transformation Program. Let's go to the next slide. So one of the things we're also trying to do is help stop this infinity sign, which is hospitals keep merging and acquiring. They bring in more revenue and profits. The revenue and profits are used to purchase more physician groups, market share, and footprint, which causes more profits, and we have this cycle. So we're trying to figure out in collaboration with hospitals, how do we help them get to the next generation without this infinity of more and more focus on market share, and how do we get more and more focus on closing disparities, affordability, quality outcomes, health improvement, those sort of focus areas. Let's go to the next slide. So the department, now when that happens on the hospital side, it benefits Medicaid. We've got about $2 billion that goes towards hospital with supplemental payments. About $3 billion of our payments go to hospitals. It's our largest area of payment, as it is for all employers and all health plans. We also are focused on prescription drugs. So prescription drugs are the fastest growing part of the healthcare dollar. Outpatient hospital is second. If we don't get this under control, we're going to continue to have this problem, and it's very real. 1 in 3 Coloradans can't fill a prescription. They cut pills in half. They skip doses because of cost. So we've got to get this down for equality and outcomes, a health disparity issue, and an affordability issue. Let's go to the next slide. So we're very focused. We issued a report, came out last January, had a big summit in January, and we had solutions that we can control at the state level and solutions that we can control at the federal level. This first federal, things like patent exclusivity, direct-to-consumer advertising. Let's negotiate some prices through the FDA approval process and learn from Medicaid policy. Employer costs are constantly going up, and Medicaid costs for pharmacy are going down. So they're completely contrarian by more 50% spread. So how can we learn employers from Medicaid? And we're working a lot on that. Let's go to the next slide. Let's talk about some of the things going on in the state. We start with the bottom up. Passed in this past session, a prescription drug affordability board helped do that through analysis. We know that 50% of prescription drugs, the cost of prescription drugs, are being driven by specialty drugs. Less than 2%. Drugs are so expensive, they're driving now 50% of the spend. And that's where the biggest rise in healthcare costs is, specialty drugs within pharma. So we help to drive policy as the biggest payer. This will set up our payment limits. The governor just appointed the board that will be that prescription drug affordability board. Now in the process of hiring an executive director to help manage that board and appointing the advisory panel. Other issues, maybe we should do a rebate pass-through, about 20 cents on every dollar for prescription drug. And we want to make sure that those monies are passing through to employers to help reduce employers' costs. So that's an opportunity versus just staying in the pockets of the insurance companies as profit or the PBMs. Value-based contracts, importation could save us over more than 60%, and the prescriber tool I'll talk to in just a minute. Let's go to the next slide. So as we look at healthcare policy and financing, when you cover 1 in 4 Coloradans, boy, we want to be thoughtful about value-based payments. We want to move from fee-for-service, which encourages providers to just do more and more unit cost billings versus getting people well. So we want to pay providers to close disparities, to improve quality outcomes, to reduce readmissions to hospital, to improve the health of Coloradans. We want to pay them that value for getting the result, not just for the episode or the care itself. So when you look at that, I just talked about the Hospital Transformation Program. That's the biggest value-based payment. I'll talk in a second about providers of distinction, the prescriber tool. We've also got a maternity bundle that'll be the first payer in the nation, the first Medicaid program, first any payer in the nation that pays OBGYN and OBGYN clinics and groups in order to close disparities, with massive disparities for mom and baby, for people of color, for low-income people, and we want to close those disparities. And this value-based payment, given that we cover 40 to 45% of the births in the state each year, we want to bring that value-based payment to make a difference in the health of Coloradans. And so let's go to we want to reward the use of tools that get to a better tomorrow. We want to reward closing disparities, quality outcomes. Let's go to the next slide and give an example. So the prescriber tool rolled out soft launch in June. One tool, we want a combination of value-based payments through carriers and Medicaid having $1 billion prescription drug spend. So we gave prescribers one central tool that all of Cigna, Aetna, Anthem, United, and Medicaid's reimbursements are in that tool. So a prescriber can now be part of the affordability solution for the number one driver of healthcare costs, and that's prescription drugs. And we want to share with those prescribers a value-based payment for being part of the affordability solution. To get at that first thing that I said, if people can't afford their drugs, they don't take them. And then they get sicker, right? And their conditions exacerbate. So we're so excited to bring this tool. Now we're rolling it out. About a quarter of Medicaid prescribers now have access to it. Value-based payments will be paid in the next fiscal year, July to June, 2022 to 2023, based on prescribers' performance this year. So we're very excited about value-based payments driving changes in prescriber behaviors that can be part of the affordability solution, getting better compliance for their patients, whether they're Medicaid or commercial, and getting a better outcome and results. Go to the next slide. We're also developing providers of distinction. What does that mean? A provider of distinction will be labeled as such when their outcomes and affordability are better than their competitors. So we want to, in Medicaid and in the commercial space, not just have, as the healthcare provider system buys up market share and they own primary care and they own specialists and they own the hospital sites, inpatient, outpatient, they own standalone clinics and imaging. We don't want them to just be self-governed and provide the care based on what they do as a revenue source or a footprint in care delivery. We want the care to go with the patient in the center, the patient, their needs being defined as they get well. And we want to recognize overall affordability. So care is affordable so people can get the care that they need, right? Because the biggest access barrier is affordability. So this specific objective is to say, what are providers of distinction for starting with about 24 different services? We'll roll out probably 12 and 24, and we'll keep going. So you might say, if I want to go get a heart procedure and I'm in Medicaid, where's the provider of distinction where the cost is reasonable and the outcomes are better? And we want to do that for employers too, so that we battle that infinity curve that we showed, and the care goes to that which has the better outcome for the patient overall. Very excited to bring that. We are deep in the weeds, and we're in collaboration with the Colorado Business Group on Health, which is in alignment with a purchaser business group on health, that will bring employers working alongside Medicaid to identify these providers of distinction. That's all going on right now. Look for lots of progress through 22 and implementation into 23 and into 24. Big deal. Next slide, please. And this is sort of a summary slide. So if you say, what is the new tomorrow? What's the new normal? The new normal is all about recognizing healthcare disparities and closing them. The new normal is all about transparency and holding everybody accountable. The new normal is all about value-based payments. How do we pay to get results, not just for individual types of care? And how do we have transparency that holds everybody accountable all along the way, whether it's prescription drugs, whether it's for us, that everybody can see into where our intentions are, all the reports. We are an open book all the time. But to bring that to prescription drugs, to bring that to hospital, to bring that to all types of care, and including the all-payer claim database to see everything about what is working. Let's go to the next slide. Okay, so I'm going to turn it over to Claire, and we're right on time. So we had about a couple minutes of introduction, 10 minutes of my piece. We're going to have Claire for 10 minutes, and then over to Greg. Claire, over to you.
Thank you so much, Kim. Thank you for that presentation. What a great way to kick us off. So thank you for having me. And we are going to talk today about some of the things that Peak is doing to address both price and affordability of care. Next slide, please. So I am Claire Brockbank. I am the CEO of Peak Health Alliance. And at Peak Health Alliance, our mission is to lower the cost of health insurance for the members of our community. We are a locally managed nonprofit health insurance purchasing alliance. It's a unique statute in the Colorado Code. We are owned by our members, and our members can be anyone who purchases commercial insurance, meaning they can be individuals, they can be small group employers, they can be large group insured employers, or they can be self-funded. They are not Medicaid or Medicare. That is, Medicaid falls into Kim's category. We are licensed and regulated by the state of Colorado, but we function entirely autonomously. So we have no state revenue or resources or support. We function as really a marketplace solution to addressing healthcare costs. Maybe more important than what we are is what we're not, because we are fairly unique. We are not an insurance company. By law, we are not allowed to bear risk. We are not a third-party administrator. We don't process claims, and we are not a medical provider. We effectively work with all three of those entities, right? We stand in the middle essentially as an ombudsman to make sure that all of those folks are accountable and transparent to the purchasers they serve. And those purchasers are our members. Next slide, please. So we said our goal was to lower health insurance premiums, and have we done that? So we feel like that's a resounding yes. We are a new organization. We started in 2020 just in Summit County, and in 2020 our estimates are that we saved about $2 million for the folks in Summit County who purchased through us. In 2021, we expanded to these additional counties you can see on the slide, another group of mountain counties and the Southwest. And we estimate we're at about $8 million in savings so far because our enrollment has gone up during this open enrollment we've just ended. These are back of the envelope calculations. We make the leap of assumption that all of our members are 40-year-old non-smokers and that they all buy the equivalent of a silver plan on the exchange, because that's where we have data that we can compare. So what's important about this slide is that we are generating savings close to 10 million now in our 2 years of existence. And that is money that goes straight back to the community for things like housing, for things like that they can use to buy those expensive pharmaceutical drugs that Kim talked about, childcare, the kinds of things that are plaguing many of our communities right now. So next slide, please. How do we do it? We're going to talk both about cost and affordability. On the cost side, really, we enter into direct negotiations with providers. So in many ways, we are an alternative to what carriers have traditionally done, in that we use a lot of data, we negotiate directly with providers, and our goal is very objective payment rates. So no discounts off bill charges. We may do percent of Medicare, flat rates, bundling. We're super excited to be following the work that Kim and her team are doing. The goal being that we are moving to a system that is not volume and fee-for-service driven. Now, what we don't do, though, is have one formula that says you must accept 250% of Medicare. We have so many different types of hospitals and providers in the state with different capabilities, and some are really leaning in and providing incredibly affordable care, and others are not. So we really use data to come up with a solution that works for both the community and the hospitals in our communities. Many of our communities are small and rural, and we don't want to lose those hospitals. So I said we're an alternative to carriers, but effectively, once we've negotiated with providers, we take that and we partner with carriers to administer what we negotiate. So essentially, again, that middleman role is in there. It's a private market approach that in an ideal world wouldn't be necessary, in all honesty. So next slide. There's one thing to talk about cost. It's another thing to talk about affordability. And we heard this a lot after our first year. When premiums dropped by about 35%, that was great news. But if you still have a really high deductible, it doesn't feel like your insurance is healthcare is not affordable. Kim talked about how many people forego medications or forego services because of the cost. So we've worked really hard to think about affordability from the perspective of our users. And so we try to make those high value services, as many as possible, in front of the deductible. So a peak member can get their outpatient primary care with no deductible. Mental health is at no cost whatsoever, no deductible and no copay. We were the first entity in the state, and I believe maybe still the only one, that had zero deductible policies in every metal tier available for our members. Now, I should qualify, these are for our insured members. Self-funded members can set their own benefit designs, and we will counsel them on things that we think drive high value, but they still get to ultimately make their own decision about benefits. Cost is not always about lowering price. So I will tell you, or price is not always about lowering what you pay doctors. So I'll tell you, we use our reimbursement philosophy to really think about what are those critical services, including mental health and imaging. Both of those entities actually get paid more under the peak model in order to promote access to them. So let's go to the next slide. So I said we pass those provider rates over to our carriers. And if our carriers have leaned in, as they have, Centura Health System, University, Children's, many of our independent providers really leaned in to reduce their prices a lot. It's our job to make sure those get passed through in terms of premium. So we often hear from carriers that that's not necessary because their profits are regulated to that 20% of the pie that the law allows them to use for profits, but that doesn't give them a big motivation to shrink the size of the pie. And our goal is to shrink the size of the pie. If the pie is insurance premiums, we want those premiums to come down. So we use an independent actuary. We really scrutinize those fees. We look at what we think they should how they should play out on premiums. And we look at rate filings. We believe we're the only entity in the state in a position to look at both the negotiated fees and the resulting premiums and say, do those match? And we do file comments with the Division of Insurance every year on the rate filings because that is part of our commitment to the provider side of the equation. So next slide. So just a quick wrap up to make sure we stay on pace. Peak is essentially a middle person between providers and carriers. We've generated premium savings of approximately 35%, varies a little bit based on benefit design in our 2 years of existence. So that means that that's separate from reinsurance. So if you live in one of our communities, your health insurance premiums are about a third of the cost of what they were in previous years. We have about 8,500 members that we serve right now, and we're approaching about 10 million in direct premium savings and continuing to work with communities to expand this model. So I'm going to stop there. We'll have time for questions later and hand it over to our illustrious Professor Tong.
All right, thanks for the intro from both of you. So hi everyone, my name is Greg Tong and I'm at the Colorado School of Public Health. And I'm going to be talking to you about some work that we've done for the Healthcare Cost Analysis Task Force, a little bit more specifically, some cost estimates that we've generated for our current healthcare system here in Colorado, and then some reform options, some version of a public option and some version of a single payer option. So next slide, please. So first, let me tell you just a little bit about what the Healthcare Cost Analysis Task Force is. This was a task force that was created by House Bill 19-1176. And their primary responsibility was to hire a vendor or an analyst to do these cost estimates of these three scenarios that I've already described. Again, the first is generating a reliable cost estimate for our current healthcare system. How much are we spending right now across the entire state, across all the different sectors? And then some version, or there's some nuanced language here, but some version of a public option and some version of a single payer option. And I'll tell you a little bit more about that. I also want to just touch on that everything that I'm going to be talking about and all of the activities of the task force are all publicly available on the task force website. And as you can see from this screen grab, that website is comfortably nestled within the larger web presence of the Department of Healthcare Policy and Financing. Next slide, please. I also just want to point out that I and the team at the Colorado School of Public Health, we were not actually members of the task force, but we were the contracted vendor or analyst. And so I'll tell you about the nitty-gritty and the actual cost estimates that we generated. And this is a screen grab from the cover page of the report that we submitted to the task force. This is also here to remind me to let you know that even though I have the privilege of presenting some of our findings to you today, that the body of work was conducted by a team at the Colorado School of Public Health. That also includes our dean, Jonathan Samet. Next slide, please. Okay, so I'm going to focus on the cost estimates and how we got there. And so this is just a visual that represents how we got to the cost estimates that I'll be presenting to you. I'll start off by saying that we started off with a data set called MEPS, the Medical Expenditure Panel Survey. That is a very robust and detailed data set that gives healthcare expenditures for the United States. So while that is a fantastic data set, there's a couple of problems when we think about that data set and then trying to use it to generate cost estimates for Colorado. One is the individuals in that particular data set demographically don't really look like Colorado. And the expenditures in that data set are an average for the United States, and that's different than Colorado. So the first thing that we did is we took that MEPS data set, the Medical Expenditure Panel Survey data set, and we paired it with the American Community Survey data from US Census, which is another data set that is Colorado specific that gives us a much better look and estimate, a much more representative sample of Colorado's demographics. So after we paired that expenditure survey data with the American Community Survey data, what we've got is a data set that demographically looks a lot like Colorado. We've still got a problem though, and that problem is the underlying expenditures that are tied in that data set are US average, and that's different than Colorado. So to make those estimated healthcare expenditures in that data set more representative of Colorado, we've got what is highlighted here in the second box in our figure, which is we calibrated the data to Colorado. So we went and we looked at cost estimates that existed for the different insurance segments that existed in Colorado. We took those estimates and then we rescaled or calibrated the expenditure estimates in that data set to make it more similar to Colorado. So what that's done is that gives us an effective data set to power a micro simulation to generate cost estimates for our current healthcare system, and then we can manipulate that model to generate cost estimates for alternative policy scenarios. Okay, so I'll pause there really briefly and just kind of a reality check. So if HCPUF and Kim's group were to go in and they were to look at the average expenditure of people who are insured by Medicaid in this particular data set, I can say with a high degree of confidence, it's going to match dollar for dollar. And that's because in the calibration, we took published HCPUF estimates of expenditures for members, and we used that as the calibration benchmarks to recalibrate the expenditures. And we did the same thing for the private market. We did the same thing for Medicare. The actual sources come from different places depending on the expenditures that we're calibrating to. And so then we're left with a robust data set that demographically looks like Colorado, and then from an expenditure standpoint, looks much more like Colorado as well. So I'm going to move away from this figure, but then come back to it, because from there, we're able to provide an estimate of the total cost of healthcare in Colorado. So can I get that next slide, please? And that number is $38.3 billion. It's a lot, and maybe unsurprising to you that are seeing this, because you're savvy and knowledgeable and know that healthcare costs a tremendous amount. Maybe I'll be a little bit controversial and say that I know that there are other estimates for the total cost of healthcare in Colorado. And I'll try to tamper my how controversial I'm going to be. I'll just say I think we've got one of the best going. And I'll spoil the surprise. I think one of the strengths of this particular approach is I think we've got a very valid and defensible estimate of the total cost of healthcare in the state. Okay, next slide, please. Okay, so now here's where things get a little bit more controversial. And we weren't just charged with generating a cost estimate for our current healthcare system, but we were charged with generating a cost estimate for alternative reform scenarios, specifically some version of a public option and some version of a single payer-esque type of option. But we weren't given the specifics of what those options should look like. We were just charged with generating those cost estimates. So next slide, please. So in order to do that, we had to make some assumptions. And depending on where you sit and where your perspectives lie, those assumptions could be, I'm going to say, are likely controversial, and we just embrace that and try to be transparent about that. And I'm not going to go into all of the different assumptions that we went into, but I will highlight kind of 2 bullet points or 2 general buckets of assumptions that we needed to make. And those are in line with what was the benefit design and generosity level of the reform option going to look like, both for the public option and the single payer-esque type of option, and what were the reimbursement levels going to be. So first controversial decision or assumption was we decided to benchmark our reform option off of the private market. So it is benchmarked, and the benefit design and that generosity level is based off of the private market. And so there's pros and cons to that. It is great, and it gives us additional confidence around the cost estimates and the comparability when we're comparing that to the private market. But then if we're looking at it compared to a different segment, let's say Medicaid, boy, that benefit design and that generosity level is going to look really, really different. And so that's the trade-off. From the reimbursement level standpoint, we made a decision to benchmark against Medicare. I think that's not so controversial, but what should the levels be? To try to cover our bases a little bit, we created cost estimates for a range of reimbursement levels, specifically 100, 150, 200, and 250% of Medicare. Okay, so I'm glossing over some of the details, but those are kind of some of the big examples of big assumptions that we needed to make, that we try to be really transparent and detailed in the report. Can I get the next slide, please? And voila, here's where we go. So let me walk you through this table. The columns here represent different reimbursement levels. And then what you see in the rows are the different reform options. So all the way in the upper right-hand corner, you see our old friend, $38.3 billion, which is our estimate for the current healthcare system. And the rows that are labeled 0, 10, 20% private crossover, these are just estimates for the public option. And the 0% crossover is just 0% movement from the private market into the new public option. And then 10 and 20% represent 10 and 20% movement from the private market into the new public option. And then the final row we have at the bottom is our kind of version of a single payer-esque type of cost estimates. And I think the big takeaways here is that regardless of the slight variation in flavor, what we see compared to status quo or our current healthcare system are slight cost increases of a public option, which from my standpoint makes sense because you're really just primarily plugging the uninsured hole and then providing more services and coverage for them. And where we see the potential of some cost savings is more significant reforms and moving towards something that resembles more of a single payer system. Next slide, please. And these are just those same numbers or same cost estimates, but represented as a percent of the status quo. And again, the bottom line here is all different versions of public option reforms to achieve universal coverage will produce, our estimates suggest they will produce slight increases in the total cost of our healthcare system. And then only through more significant reforms moving towards something that resembles a single payer type system do we get more significant potential savings. Next slide, please. Okay, this is my last one, and then we can move into the Q&A. And that's just I want to touch on a couple of limitations and strengths, or two limitations and two strengths that I see that come out of this. The first limitation is we did not vary the benefit generosity of the reform option in our models. And we know that that would be something that's really useful. Maybe that's something that could happen in the future. And the benefit generosity and levels that we chose, there's pros and cons. It helps with comparability compared to the private market, but then it ends up making the reform option look really, really different than the example that I brought up was Medicaid. The other big limitation I really want to emphasize is that our cost models don't consider provider financial health or retention, which is a huge issue. And I think at one point during this project, I mentioned to somebody, boy, it's really easy if you don't need to worry about the financial health of providers, hospitals, or retaining them in the state. It's very easy to design a very cost-effective or a system that helps control costs because you just bring reimbursement levels down, 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 down. In reality, if you do that, you're going to have a significant impact on provider health and retention. So our model doesn't factor that in. Despite those limitations, I think there are a couple of significant strengths. The one strength I've already touched on is I think our total cost estimate of the current healthcare system is pretty good. I welcome questions or scrutiny that people want to apply to that. And the last strength is, we now have a working microsimulation model of Colorado. So we've put a lot of time and energy into generating this microsimulation, generating a data set that is demographically representative of Colorado, that has medical and health expenditures that are representative of Colorado itself. And then that is a model that can be used in the future when we think about significant reforms or innovations that can be introduced. Not to say that the policy innovations that we're putting in right now we're introducing them and not knowing what the anticipated impacts, but I think this model gives us an additional tool to maybe try to estimate what the financial implications of those might be. So I'll stop myself there and turn it back over to you, Kim. Thank you.
Well, thank you, Dr. Tong. I think that was very insightful. I think most people, this sort of slipped under the radar that this whole 1176 was going on, and that you guys have been working pretty hard for a couple of years and released that report this year. So well done. That's a lot of work. And I appreciate you underscoring this model can be used, and that you think it's smoking. That's great. That it can be used by others going forward to figure out what do we do next to get to more affordability and continue to get people covered. So thank you for that. So just I'm going to start with you, Dr. Tong. What was most surprising that came out of this report that you just issued?
Yeah, I think one of the most surprising things to me was I went into this process thinking that reimbursement and controlling the reimbursement rates was really going to be the primary driver of cost control. And through some additional research, and actually research that I was exposed to and should have known, it's really just not that simple. Just controlling the costs is not that simple. There are other system factors, and it's much more complicated, right? So it's not just let's come in and introduce cost controls. That's going to have negative implications for the financial health of providers, retention of providers, and that's not going to achieve the type of cost controls, overall cost controls that I feel like our system really needs. And it's actually much more complicated. It's more of a systems-based approach, and it's thinking about not just controlling the cost, but value-based payments, all these other types of things that are factored into our cost model as well.
Thank you. Yeah, no, that's good. I appreciate that. So Claire, I'm going to ask you a question, then I'm going to answer it myself since there's three of us and I'm playing a couple of roles here. But you're sitting in a position and you're dealing with the whole industry, right? You're dealing with providers, you're dealing with payers. Can you just share your thoughts on what do you want the industry to do a little more of, and what do you want the industry to do a little less of? You can talk from the perspective of payers, or you can talk from the perspective of providers.
It's a great question, Kim. I would like to see the providers focus more on what they can do as opposed to what they've been doing. I think there's a great fear of changing their model and of moving from fee for service and moving from keeping that black box and getting reimbursement at all costs, and thinking more about sort of that long-term healthcare ecosystem, that if people continue to forego care because it's too affordable, they continue to put, to make decisions that don't make sense, to do some of the things that you all are doing, right? To drive to a more logical macro perspective, right, of where to use your healthcare dollars. And I do think, Greg, Dr. Tong, I do agree that it's a complex thing, but the prices that we pay in Colorado are extraordinarily high in the commercial market for many of these services. And I think there is so much room for improvement. So that's what I'd like to see. And I will say that I think there are providers who are really stepping up to that. But there are many who are not, who are holding on to the old way of doing things. On the carrier side, I would say that carriers, our perception is that some of the larger carriers, they are very, again, bound up in how they're doing things, and their national infrastructure sometimes keeps them from thinking about innovation at a state level or at a Colorado level. And it would be, I understand the issue of scale, but the constant consolidation on both providers and carriers limits the ability to try new things and to innovate new things, because to do anything new, they're turning a whole ocean liner. So in that sense, some of the new carriers that have come into the market, the Brights, the Oscars, the Fridays, they are more nimble, and they are serving as a fantastic laboratory of different things we could do. And I would love to see the larger national systems who have so many resources at their disposal think about a way to introduce a little more ability to innovate and be flexible and try new things.
Thank you. I appreciate that. I would love to see our delivery system continue to do the wonderful things they're doing right now in community investments around vaccines. So many are stepping up. I'd love to see continuation of that, more folks delivering vaccines, making it easier for Coloradans to get vaccinated. It's one of the most important things we can do to close disparities. And it would set the example of what we can do when we work together to battle something as difficult as a global pandemic that preys upon the most vulnerable. That addressing disparities needs to be part of our new normal, and the lens and the optics that we look at things every single day. So I'd love to see payers and providers focus on disparities, using COVID as an example, because it's really shined a light on the enormity of disparities that have been there all along. I'd also love to see, we learned through telehealth and COVID that we can change on a dime when we need to. And we moved really fast. The federal government moved with COVID. Telehealth forced us to move with COVID because everybody's in their house. And we changed on a dime, and the innovations brought so much access that we didn't have before. Love to see more of that. The collaboration, we've really shown how much we can collaborate when times get tough. And we've worked so well together, the state and providers, the state and carriers. And I know sometimes it can get contentious because we're inserting ourselves as a department trying to drive affordability, which means we're interrupting somebody's revenue stream. We get that. So I would ask, continue to do more of affordability, every part of the system, carriers and providers alike, payers and providers alike, including Medicaid, and know that means you're going to have a little bit revenue interruption, but we have to step up for the good of Coloradans and employers. We all have to step up, and it means our business is going to get harder. And at Claire's point, we got to do things differently, and we got to change, or we're going to get more of the same, and yesterday isn't good enough. I'll leave it at that, and I'm going to transition to the question from Jason Smith, and others would invite you to add your questions into the chat. But Jason said, so I just touched on it. What lessons have you all learned from COVID related to purchaser strategies? In what ways have your strategies changed? So Claire, I'll start with you on that.
I will say that one of the things that's incredibly important about Peak's work is educating the community that it is feasible to do something better. And that healthcare, yes, it's complicated and confusing, but that it is worth engaging in and learning about the difference between price and cost and how all those dynamics, and why you should pay for mental health services because it ultimately benefits the community. And that ability to engage the community in those really direct educational forums and community sessions where they were able to share their stories and start to learn was severely hampered. And I believe that that level of community education, which I believe is what it takes to drive change in many communities. The community has to say it matters to us. They said what matters is COVID, right, Kim? And so we did see some fantastic things. But we also saw a great deal of hesitation in many communities to do anything to jeopardize the hard work that their local hospitals were doing and that their local frontline providers were doing. And so I think as a result, I believe efforts to change at a system level were stymied because of all that energy having to go to COVID. I'm not saying they were inappropriately stymied, but I believe it definitely put a pause on some of the efforts to embrace more systemic change that was not specifically related to COVID.
Thank you. Okay, Dr. Tong, I'm going to ask you this one. It's from Josh Ewing over at CHA.
Yeah.
He says, yep, according to the Chase report, Medicare currently reimburses about 72 cents on the dollar of services provided, and Medicaid about 75 cents. Yay, Medicaid, paying higher in Medicare. Thank you. The remainder of this cost is borne by the privately insured market. I appreciate that you acknowledge that analysis doesn't take into account the impact of providers, but did your analysis look at the impact of increasing public payer reimbursement?
Yeah, the short answer, that's a great question. The short answer to that is yes, we did. I will confess that we haven't formally done a decomposition analysis, but if you go back and you look at the reimbursement levels and who's included in those reimbursement levels, in some reform options, we are pulling in public payers into the new reform option and would effectively increase the reimbursement rate for that segment of the population. The other thing I'll mention, I know we're short on time. The other thing I mentioned is this issue that you raise is a very significant one that I dealt with myself. And my quick confession is I'm an academic late bloomer. But before I did my PhD, I did 10 years in hospital finance, administration, and management. I'm very familiar with the different reimbursement rates and the struggles and getting that right payer mix and balancing that against the broader mission of the institution. So it's a tough position to be in. Again, I'll go back to your core question. The answer is yes.
So I want to thank everybody for all of your time. Thank you for the preparation. Audience, thank you for your attendance. There's a couple questions we didn't get to. And I would encourage you all to continue to follow the state of reforms. Lots of good sessions. Thank you very much and have a wonderful day. Take care.
Thank you, everybody.